that we see a lot that is not, everybody thinks they know what it is, but in truth, there's really not a lot of good information written about this, but you're going to see a lot of it. Next, please. So this is the epidemiology of it, and there are two ways really you can get it: congenital and acquired. You can see that that the acquired type is more prevalent than the congenital type. And let me see, very high confidence intervals with respect to acquired in any type. Go ahead and go to the next one. There isn't any official definition of what it is. But as we go through this, you're going to see that oftentimes it's not a single structure that's affected. And the end result is, in the clinical presentation, is pain in the legs, which is worse with weight bearing and better with non-weight bearing. And this is one of the ways you can differentiate what some people call neurogenic claudication from vascular claudication. So the vascular patient, when they walk, contract their muscles, which limits their circulation. And if they stop walking and stand for a minute, their legs will get better. The neurogenic claudication patient won't. They will have to sit down and unload the spine in some way before they feel better. Oftentimes they'll tell you if they lean forward, they can do okay, but if they try to stand straight, they don't feel so well. Oftentimes the spouse or significant other will tell you, you know, he or she walks around the house bent over and you know, something's wrong. So that we'll get into more of the history taking, because I think that's important for everyone to understand. Next, please. So these are the structures, and there will be a little picture here coming up in the next few slides that we'll talk about further, but it's multifactorial. So as we age, after the actually the beginning of the third decade, the disc starts to lose its vascularity, and that's when you start to get annular tearing and disc bulging, where the nucleus pushes through or pushes against the annulus. The lateral foramen starts to get stenotic from osteoarthritis. The lateral recess, where a lot of this happens, is affected by not only the lateral foraminal osteoarthritis, but bulging discs and lipping of the vertebral bodies. The facet joints make up the posterior part of the lateral foramen, and they can have some exuberant bone, which also has a role to play. And then, as I mentioned, the vertebral body lipping. Next, please. So what you're seeing here is the motion segment. So the spine is made up of motion segments. Each motion segment is made up of two vertebral bodies and the disc and both of the facet joints. And so you can see there, this represents a fairly normal one, that in the back, which would be to your right, where the facet joints are, those are circumferential joints. And those are just like your knee or your hip. They have a capsule with synovium and the whole 9 yards. And as they start to get arthritic, they don't just get arthritic in the back, but they get arthritic in the front, and they can impinge on that foramen. And that nerve root there is depicted with the dorsal root ganglion right there in the foramen. Next, please. So on the left is what this would look like from the top in a normal canal. And what you're seeing there posteriorly, obviously, is the spinous process. And those two little horns that are just lateral to the spinous process are most likely the inferior articulating process of this vertebral body that are going to make part of the facet joint. And you see the canal there. You see the ligamentum flavum, very nicely colored yellow, so you know what it is. And then on the right, it shows you what's occurring. So they've taken this picture on the right a little bit farther up, and what you're seeing there, those fine lines that extend from the spinal canal posteriorly are trying to depict the facet joints. You can see that they're osteoarthritic. You can see the ligamentum flavum is thickened, and all of that goes together. They're trying to depict here annular tearing. They're trying to depict vertebral body lipping. Next, please. This is what it would look like in its most severe case. So generally, when you're looking at the MRI in the lateral view or the sagittal view, if you want to call it that, you see a loss of disc height. You see bulging of discs and lipping of the vertebrae. You see facet joint arthritis, all coming together to impinge on, in the lumbar area, the cauda equina, and in the cervical area, the whole cord. Next, please. This is what you see. So generally, they have extremity pain, one or both legs. Oftentimes, they'll tell you, my legs get tired. They don't hurt, but if I walk a little bit, they get tired. In the West Virginia setting, you'll hear 100 times, when I go to the mailbox, I have to stop halfway and take a rest on the way down and on the way back. Oftentimes, they'll complain of numb feelings, and calf cramping is very common. So that's why it's important to have always in your mind how I divide this from vascular problems to neurogenic problems. When you're looking at facet disease, many times they'll tell you that they're worse with extension or rotation. And so for the women you see, they'll tell you, when I run the sweeper, it hurts. And the men will tell you, when I run the weed eater, it hurts. Because that is a forced extension and rotation which presses together the two bony parts of the facet joint and makes them have pain. This is a part of stenosis, but not necessarily, it can be seen as its own entity. We talked about the history. They'll say if I'm cooking in the kitchen and I sit down, or I sit in the recliner, or if I'm at the store and I lean on the cart, I can go all day. And as I said before, they have to unload their spine. Just stopping activity won't do it. Next. This is what it looks like in an MRI. You see there at the L3-4 interspace a bulging disc. You see exuberant facet joints. When you look, if you look through the markers, you can see that the posterior aspect of the spinal canal, where the CSF is, it looks like a scalloped edge. That's because of the thickening of the ligamentum flavum, and where that thing says, a bracket that says spinal stenosis, that's a hugely thick ligamentum flavum there that's impinging on the central canal. This may not be symptomatic, but it is a good depiction of what you'll see. Next, please. This is what they're showing you here as a, basically, as you look at this, toward the left of the picture, which would be the patient's right, you can see in the lateral foramen that root coming off the cord it just has a super highway there to get to where it needs to get. But on the right, you see that there's facet joint bone right in the middle of the way there. Next, please. So what do? Well, you start conservatively, and depending, of course, on the history of how long they've had the problem. Oftentimes, they'll tell you, individuals will tell you, and this is a disease of people generally over 50. And so they'll say, I've had this for 2 or 3 years, but in the last 6 or 8 months, it's really bad to where it's affected me. Those are patients you have a chance to help. If they tell you that they've had it for years and years and years, you can try these things, and you should, but generally you're looking at a decompressive surgery. So you start out with the usual things. You try to get them physiologically into flexion, whatever that takes. So generally you have to get the abdominals a little stronger and the back strong but not as strong, and hamstring flexibility, and trying to get the pelvis to tilt backwards so that you create an opening so that they decompress themselves. Epidurals work. We use them. This is probably the #1 indication for epidural steroid injections. Next, please. That's it. Any questions? Okay.